and Asian countries, limited access to the health and patient anxiety to several health service. Postponement of antenatal and pandemic care during COVID-19, which less prioritizing station in the vaccination plan or could be possible explanation for the maternal morbidity, preterm birth, and even mortality occurring. As we are under the partnership project on global health and universal health coverage, GLO and UHC, that aim to promote UHC in the member along with the commitment to the Sustainable Development Goal. The goal 3.1 was committed that by 2030 member states shall reduce the global maternal mortality ratio to less than 70 per 100,000 live births, and the global 3.2 was stated that by 2030 we shall end preventable death of newborn and children under 5 years of age. With all countries aim to reduce neonatal mortality to at risk as low as 12 per 1,000 live births and under 5 mortality to at least as low as 25 per 1,000 live births. This goal was challenged by the COVID-19 tsunami in terms of the impact and process outcome. This PMAC 2022, we aim to build the world we want and prepare ourselves to be resilient to any possible threat by translating our experience from the COVID-19 global pandemic. It was my pleasure to see this meaningful side meeting consists of national experts. Cambodia and Japan. Our speaker will present success and challenge in the maternal and child health affected by the COVID-19 pandemic, in which this variable input will result to further discussion to protect maternal and child health from the COVID-19 and any further pandemic threat. I need to emphasize that there are several tasks that waiting for the clear and correct direction, such as appropriate method for the new normal antenatal and pediatric care, evidence to support vaccination in the pregnant women and children, and most important, advocacy method to push this agenda forward. Therefore, experience sharing and constructive idea that will be the next tool how would be essential to the complete the picture perfect in the maternal and child health service in the future. All in all, I wish you all fruitful discussion. I sincerely appreciate and understand as a courage that have been told this past movement, and I am looking forward to learning for your experience. Thank you very much.
Thank you so much to Dr. Attapon Kaosapri. Deputy Director General from Department of Health, Ministry of Public Health. And now we will have the country presentation. But before the country presentation, I would like to introduce something about the theme and objectives of this meeting. And we know that and in these 2 years, the COVID-19 pandemic is made the trouble in each country that increase in severe maternal morbidity, maternal mortality, and also preterm birth. And we learn from each country around the world that 20 to 40% of the pregnant women have died from the COVID-19. And in Thailand, also around 40% of the pregnant women passed away from the COVID-19 in this year. And also, we learned that in each country have the situation of increasing in deaths of caregivers, and we have the orphanhood. That this is a very serious issue in every country. And from the record around the world, around 1 million children have died. Around 1 million children have lost one or both parents during this year of pandemic. So this is very significant, very important from the pandemic that affects the mother and child. So the objective of this meeting, first, to review the direct and indirect impact of the COVID-19 pandemic to the maternal and child health in each country. And also, we want to share the knowledge that about the lesson we learned from each country during the crisis, how to protect maternal and child health from every country. And finally, we want to identify the policy implications on how to respond to the mother and to protect the mother and child in each country in the future. And now I would like to go to the next section about the country presentation to learn about the good practices and challenges in protection of maternal and child health under the pandemic of COVID-19. And we will start with Thailand. And each country have only 12 minutes for presentation. And now I would like to introduce Dr. Pimonpan Tangvivat, Deputy Director of Bureau of Health Promotion, and also the head of Mother and Child Health Group from Department of Health, Ministry of Public Health. And now, starting with Thailand, Dr. Pimonpan Tangvivat.
Thank you very much, Dr. Ekachai, my boss. Good morning, good afternoon, and good evening, distinguished guests. I am Dr. Pimonpan Tangvivat from Department of Health, Ministry of Public Health. And today is my honor to present you the good practice. Good practices and challenges in the protection of maternal and child health under the pandemic of COVID-19, the lesson learned from Thailand. Next slide, please. An outline of this presentation will start with COVID-19 situation and impact in Thailand, and followed by efforts implemented to respond to the impact, and end with remaining challenges and lessons learned. Next slide, please. Start with COVID-19 situation and impact in Thailand. Please, yes. The total COVID-19 infection cases among pregnant women from the 1st of April to 18th of December 2021, there were 6,208 cases. And 519 cases were vaccinated. And among these, 291 cases were newborn. 104 maternal deaths occurred, which is around 1.6% of 1.6% mortality rate. This rate is twice higher than the death rate of normal population. We have 59 newborn deaths, and it is around 60% is stillbirth. However, please be note that this data has acquired from hospital report, not the central reporting system. Therefore, it could be slightly underestimated for the infected case, but the death case were all verified. Next slide, please. In 2020, Thailand has performed well in controlling the pandemic. However, when the second and third wave strike, the peak new cases per day has gone up to 20,000 per day. That hardship will period consume all health resources, including human bed occupancy and medical supplies. Most routine and non-urgent health services, including antenatal care services, were postponed. And furthermore, pregnant women were worried in COVID-19 infection and leads to avoidance of antenatal care visit, while those who decided to continue antenatal care experienced transportation difficulty. The data from the National Health Security Office, who took care of 75% of Thai population, reported a higher eclampsia and gestational diabetes rate of 10% and 4% higher than the prediction level. This could result from challenges in routine services. More importantly, Thailand has always achieved in maternal mortality reduction. However, in 2021, the actual death rate has gone to 76% higher than the prediction level. This rate could include the death from the COVID-19 related infection. Next slide, please. As we have seen many trouble in health system as shown, our effort to mitigate the impact are as following. Next slide, please. There are 4 components of action to avert the chaos. The first is service delivery, and then public communication, and work from home policy, and final, the vaccination. We have transformed service delivery into telemedicine instead of in-person delivery. However, some service still need to meet face-to-face. Then we have modified antenatal service to the one-stop service in order to reduce contact point and to reduce time consumption. We ensure supportive referral system that include teleconsultation prior to the referral. This mechanism needs a strong collaboration of maternal and child health board or network in the area. The greatest foundation is the universal health coverage. We have committed to leaving no one behind. Therefore, we have extend services to pregnant women who is the migrant worker. The public communication in individual preventive measure is critical. Thailand has always emphasized in this message through the pandemic period. This message also sent to pregnant women through hospital services such as antenatal care clinic in order to increase their awareness to personal protection. The communication tool includes infographic, video, and other media. Pregnant women were also encouraged to work from home, especially those with higher risk factor with COVID-19 severity and complications, such as those in the third trimester, pregnancy with diabetes, hypertension, chronic lung diseases, and also the pregnant women who have not got vaccine. We have noticed that private sector have good compliance to this policy as we ask for the cooperation. Next slide, please. COVID-19 vaccine were low in supply but high in demand. This pushed country to prioritize in vaccine rollout. At the beginning, those priority group were elders and people with chronic diseases group without pregnant women. However, from the evidence, we have noticed a higher mortality rate among pregnant women compared with the general working age population. We then find partners who will help advocate vaccine for pregnant women, which are HITAP or the Health Intervention and Technology Assessment Program team, and executives who involve the policy and the main EOC of the MOPH and the academia to include pregnant women as the age group, the 8 priority group to get vaccine. In parallel, we also collaborate with the Royal Thai College of Obstetricians and Gynecologists to draft and announce the COVID-19 vaccine in pregnant women guidelines. Following all those efforts, we have continuously communicated with pregnant women and their family to receive COVID-19 vaccine as soon as possible. Next slide, please. Now we have came to the last session of remaining challenges and the way forward. A few challenges have been identified in this pandemic. Data system in Thailand are still incomplete, as when sometimes it requires double effort to provide data input. It leads to neglect in data input and under-reporting cases, as they perceive that this action did not yield their benefit and increase their burden of workload. The second challenge is the fake news that we have faced throughout the vaccination campaign. COVID-19 vaccine has become political tool, and this deteriorates public trust and leads to vaccine hesitancy. The hesitancy also extended to the healthcare worker. Therefore, they reluctant to encourage the pregnant women to receive vaccine. The final challenge is the inequitable resources allocation. The antenatal care services and other non-COVID-19 related were less prioritized. The vaccine were allocated in other groups such as elders, people with chronic diseases, and children aged over 12 years old, but not pregnant women. To ensure system resilience, we need to create strong maternal and child health network for referral system between each hospital, which include well-functioning maternal and child health database. Those service delivery such as telemedicine and one-stop services in ANC shall also be embedded in the system, as this could lead to higher system efficiency to prepare for another impact. Apart from long-term investment, we shall communicate. Next slide, please. Apart from long-term investment, we shall communicate about vaccine literacy through social media, healthcare workers, and the public. This may encourage pregnant women to receive vaccine and to reduce the hesitancy level.
Thank you so much, Dr. Pimon Pantrambat, for excellent presentation. And now I would like to introduce Dr. Jan Kam,ใช่ไหมครับอ่านไม่ถูกนะครับต้องขอโทษด้วยVice Head of the Administration, Planning, Monitoring, and Evaluation Division, Maternal and Child Health Center from Ministry of Health, Lao PDR ครับขอเชิญดร.จันคำได้เลยครับไม่ทราบพูดชื่อถูกไหมครับ
เจ้าชื่อเจ้าขอบใจ
ครับครับขอเชิญเลย
ครับสวัสดีทุกท่าน Good evening, ladies and gentlemen, and thank you to Chair for inviting me for this talk. Can I share my screen or anyone can assist me to share it?
Please share your screen.
Okay. Thank you again. So for give me an opportunity to speak on behalf of Laos, especially during the pandemic, how its effect on maternal and child health in Laos. This is the outline of my presentation today. So there are 4 points that I'm going to present today meeting. So first, I'm going to a little bit brief about the COVID pandemic in Laos. As you see this chart, you see that the cases very small in the beginning of the year, but if you see in the late of September, the number increasingly very rapidly. So today, the cases we already reached around 100,000 already nationwide, and we have 284 dead cases. And those among those we have 6 maternal death. And in Laos, the situation of health in Laos, every single day, 1 pregnant woman and 20 children die every day. And this is just would like to share with you the care pathway for COVID care in Laos. Since just recently, we just endorsed the home care or home isolation policy in the nation. And now we have the designated hospital. We have designated hospital. We have only in the provincial and in the central hospital as a designated hospital for the COVID cases, severe COVID cases. But we have the isolation facility, and also the home care, and also the home quarantine. Sorry. So I just wanted to brief you a bit about the care pathway for the COVID response. So if there are any cases confirmed but no symptom, they will be kept at home for quarantine, and also they will be kept at home for home care themselves. If the condition is severe, they can refer to the hospital. We also have a hotline for the consultation for any cases that are there confirmed case at home through 164. And this is just would like to share with you the utilization of the RMNCAH in Laos. I compare by quarter, but if you can see, the number is not quite high, but in the under 5-year child have the diarrhea. If we see the cases, we can see the decline of number, but we are not really sure that this is really actual number of new cases, or maybe the decline due to the pandemic. Maybe the parents not really confident to take the children to the hospital. So we try to promote it. Any unwell children, they have to seek for help in the hospital or in the health facility. So this just would like to share a bit. There are some essential services have been disrupted during the pandemic. Even though we cannot catch up with the pre-pandemic level. So as you can see, the last new user, if comparing those 4 years, they have some decline. But in the last quarter of this year, we cannot get the data because our data is quite tricky. We will get the quarter when in January 25th. So I could not get this data for today's meeting. So this is the challenging and the action that we take to respond to the challenging. Actually, they have several challenging, but we just selected only 3 challenging that I think is very critical, and what we are take action on the challenging. The first challenging is about the increasing burden against COVID-19 response at the health facility, especially in the designated health facility, like I mentioned earlier, in provincial hospital and in the central hospital, because we have only 17 provincial hospital and 8 central hospital nationwide. So the action then we take to respond to this, we develop the RMNCS model by using the data to develop a recommendation on that. And for the second challenging, about the quality of care during the pandemic. So we know that when the pandemic is coming, the quality may be the quality may be some issue that we have to concern about that. So the action that we take for this, we also use the data that we have to recommend for the safe provision for RMNCAH services during the COVID pandemic. So, but the third challenging is about the low uptake of RMNCS essential at the health facility, as the earlier presentation that I showed the utilization. We have some disruption of the services during this time. So the action that we do during this pandemic, we try to strengthen the local health governance on primary health care and enhancing the community engagement in the time of COVID. I will go in detail a bit on each action that we take for respond in this period. For the first challenging to the increasing of the pandemic in the nation. So in the right side that you see the essential health service package just recently endorsed, and then in this essential we have around 121 essential services, and half of them is related to RMNC services. In each level, we define in different level, different services availability in the health facility. So as I mentioned, COVID-19 designated facility is only in the provincial hospital and central hospital, is if compared to other countries, very small number. So the service on RMNCs that we developed the model during COVID-19 pandemic here, we developed based on those 4 data that we have. First is about the essential health services package. The second is about the data on utilization, and we use the DSS2 as a main resource for that. And the third is about the readiness. The readiness here include the availability of the medication and equipment, and also include the skilled human resource. We also have this data from the quality assessment in 2018 and baseline survey in 2019. And the fourth data that we have for developing this model is the quality of healthcare. We also have this data from our quality assessment. This assessment is conducted in 2018 for the midterm review of the strategy. And for this, as I mentioned, we have 4 sources of data for the developing of the RMCS services model. As you can see in the table, in the blue table here, we have routine ANC or internal care in all levels, except in the community. Why we mean community here? Community here means that the person who provide very minimum and basic health issue, or for example, they provide only like ORS for children, or maybe can be just distribute some family commodity. So, but for ANC, all services available from outreach, from health center, district hospital, and central and provincial hospital. For the second data that we use for this development module is the service utilization. If you can see in the table here, more than 70% of the first ANC are provided at district and health center. So for example, the 41% is from health center and 20% is from district hospital. So it can, this is something that we use for recommendation for the services, to shifting services during the COVID-19. Then the third, the readiness, where the services readiness. So if we use some proxy item, some proxy element that to assess as a readiness for the ANC, for example, like iron folic acid or human resource for ANC. So when we see this data, and we can produce some document, a recommendation, apart from readiness, also quality, also the other thing that we use for developing this model for the services. So by using this data, we recommend that ANC should be provided in the health center or district level, rather than provided in the provincial and central hospital, especially during the pandemic, because this hospital, provincial and central hospital, become the designated hospital for cases, COVID-19 cases. So when we have this risk information, and then we can recommend for this service should be available in the health center and in the district hospital. And for the second challenging, mine is not fully seen here. So for the second challenge, the quality of healthcare on the services for target population for COVID-19, in order to make sure that high quality is provided, we just recently endorsed the shared provision of RMNCS essential services in the time of COVID. There is around 41 recommendation in this. So in order to make sure that we can promote a routine or essential service to take place in every level that we can provide it. So this is something that are very recently new and promoted and using nationwide now, and to ensure that we can provide good quality for maternal and child in Laos with safe. And this just would like to share with you a bit about the role of the community. So because we know that in order to protecting the community should be the person who are ownership for their own house. So we have several roles for the community, but in terms of how we may not be able to promote it is effectively and efficiency, we have to work with another sector beyond how. Now we have the module that we work with Ministry of MOPH and with the state government, and in order to promote the essential health services in the nation, especially in the health facility in the community, as we call health center, because they are close to the community. This is just would like to share with you the role. I will not go in detail, so you can read through this presentation because I know that we have limitation of time. So this is the challenging earth that we respond is about the low uptake of RMN's essential services at the health facility. What we doing, we have what we call the project or program we call a Connect. Connect means we try to build a capacity in the community. So we have several activities and go to the community. We let the help, we let the villager in the community share their knowledge, and they can identify their strength. They can identify the resources and how can they improve the health of the community themselves. So because the community, if they are not participate, they are not engaging, we are not really sure that even we have the good project in the community, but we don't have participate from the community is very something that is not sustainability. So as you can see in the picture here, in the right side here, we let them draw the map of the village and draw their own house, where the house is, and then next to the house, there were any pregnant women, any children under 5 around the house or not, and they have to draw, and then they have to share whatever they have in the community, what the strength that they can do. And during this activity, we also have the planning session that we include the target population, for example, like a pregnant woman or union woman in the community to pass as a planning session, because if they make the plan themselves, they're going to implement. So if before we used to make the plan for bottom up, but now from the top down. But now we try to make the plan themselves, what the plan they're going to implement it. And this is something that we try to have more participants in the community. So the other thing that we, through this activity, we also try to promote what we call the positive approach. And also we try to build the trust among the community itself, among the health provider in the health facility with the villagers. So if they understand, they have good relationship, they're trusting each other, so they're going to utilize the services. So from here, before this activity, we have the low number of services in the designated project that we have been done, but after that we see some results, good result. So as I mentioned, multi-sector should be involved in the community health. Only health sector is not really successful in any project in our country. So this is something that we see after they conducted the Connect or the community engagement in the area that we designated for the project. So as you can see in the right hand here, we call the orange tree, this is designed by the villagers, and they have to improve themselves. So during this activity, they identify those 3 objectives: building the relationship, this between the villager and with the health provider in the health facility based in the community. And also they also have some objective on the COVID response, and also how they can increase the uptake in the community themselves. So this is they identify and they also have some activity that health provider put some comment box for the village that they can have more comment to improve the services in the community. And as the result, as I mentioned, we have to have some health center reported increase in services. For example, before the same period of this time that we conducted this project or this activity in the committee, the number of ANC increased. So it's just these only two areas that we are conducted, but we see the result is quite, we are quite happy with those results. So also in the other activity regarding to the pandemic, in Lao language here, maybe they write it here, they hampan, we consider is the meaning is quite sensitive, but when we turn this meaning to positive view, and like you have to share and you have to participate in encouraging the people who are risky, rather than they say, okay, do not touch this area, do not go this area. Did you just turn their attention to have the opinion on person who have been affected for the COVID? So it's something that we know that sometimes it's quite stigma if the cases happen in their own community. So we try to let them know that even they are affected, we as a community, we have to get in hand and supporting them. This is what we are done now. This is the summary of my presentation. So as I mentioned, we have several data that can be we can use for the developing for the RMC services during the COVID-19, and evidence-based guidance guide healthcare provider to deliver high quality RMC essential services to the client regarding to COVID-19 infection status, and community engagement model can be promoted beyond health sector. So this is the end of my presentation. Thank you.
Thank you so much, Dr. Jantam, for your nice presentation. And next, go to Dr. Masashi Deguchi, specially appointed professor of Kobe University, graduated School of Medicine from Japan.
Okay, thank you very much. At first, I will share the presentation. Oops. Yeah. Can you see my slides?
Oh, we cannot see
Yet.
it now.
Maybe. Oh, this. Is it okay? Can you see?
Yes.
Yes.
Okay. It's a great honor to be able to speak to you today. Before I start, I'd like to thank Dr. Ekachai for inviting me to speak today. I'm Dr. Deguchi from Department of OBGYN Kobe University Hospital at Kobe, Japan. I'm just a researcher and physician of University Hospital. So my presentation, my perspective can be a little bit different from other speakers, maybe. Today, I'd like to talk about how we keep maternal healthcare under the pandemic of COVID-19 in Japan. Here is the outline of my presentation. To keep maternal healthcare under the COVID-19 pandemic, at first, we provide information and advice about pregnancy and COVID-19 for pregnant women and women trying to conceive. To inform women preventing infection might be a first step to keep less pregnant COVID-19 patients, and it helps us to keep obstetrical care in pandemic. We also provide information and made guidelines for obstetricians and midwives. And we started Japan Registry of COVID-19 in pregnancy to obtain original evidence in Japan. And original evidence was used to update information and guidelines. First, I tell about this promotional activity, then our registry. I'd like to start by talking about promotional activity for non-healthcare providers. Our first date for non-healthcare providers was on February 1st, 2020. 11 days before the first report of COVID-19 in pregnancy from Wuhan on Lancet. So first statement was not so evidence-based, but on experience-based. However, I would like to emphasize that it already contains very important information, such as possibility of exacerbation of pneumonia during pregnancy and recommendation about prevention of infection. At first, mask was weak recommendation because at that time we don't have enough evidence about mask and to prevent infection. But in Japan, to wear mask is not uncommon during flu or pollen allergy season. So we include it in our state. Possibility of exacerbation of pneumonia was just because generally there is an increased risk in pregnant women with common pneumonia compared with those who are not pregnant. And we update very frequently, at first month 6 times, at first year 12 times, based on new evidence. Our latest state is 13th edition on April 20 this year, based on latest evidence. It tells no severe effect to pregnancy and fetus, but sporadic pollen reports shows pregnancy loss or mother to children, child infection. The main point of the information, risk of severe illness, prevention of infection is slightly changed. We had some of stay at home or keep social distance. We had someone, but key concept is not so different from first one. Furthermore, we recommend routine prenatal care and prenatal routine visit, checkup visit for women without symptoms. By this, we try to manage both normal prenatal care and prenatal COVID care. Next, I'll show you the digest result of our registry of COVID-19 in pregnancy. In our registry, 346 cases were registered until the end of this October. Upper figure shows the number of all new patients in Japan by day reported by NHK. We have 5 peaks, 5 waves until now. Lower figure shows the number of registered pregnancy cases by month. Peak or wave of COVID-19 is in parallel with number of new patients. A case in 5th wave might be in the way of registration. Actually, we have 100 or more new registration in November. This shows the distribution of patients based on severity classification. A mild case was 70%, and moderate case who had low O2 saturation was 14%. And severe case who need oxygen but not necessarily mechanical ventilation was 15%. Patients who need mechanical ventilation or ECMO was only 1.7%. And in our registry, no maternal death was reported in our registry. Here, pregnancy outcome of all 186 cases we could follow up within 346 is shown in this table. Of 186, miscarriage observed only in 2 cases, 1.1%. stillbirth, one case 0.5%. Miscarriage or stillbirth seems not so much increased in COVID pregnancy in Japan. But in stillbirth case, SARS-CoV-2 RNA was detected in placenta, so further analysis should be necessary with larger number of cases. And this figure is a little bit complicated, but it shows the relationship between gestational age at diagnosis and gestational age at delivery or delivery mode within mild to moderate disease. Horizontal axis shows the gestational age at diagnosis, gestational week shows. And vertical axis shows period from diagnosis to delivery, days after diagnosis. Then this orange line shows means delivery at 24 weeks. This light green 28, 32, 36, 40 gestational weeks. Vaginal birth case were plotted with circle. And cesarean on obstetrical request was triangle, and cesarean due to COVID-19 with square. You can see most of the cases diagnosis before 34 to 36 weeks were managed expectantly, and after they recovered from COVID, delivered around full term based on obstetrical indication. You can see no square plot. Only 3 cases were necessary to deliver due to onset, preeclampsia, and NRFS. They are delivered within 2 weeks after diagnosis. However, 2/3 of mild to moderate cases diagnosis after 34 to 36 gestational week delivered cesarean as indication with COVID-19. These squares, you can see these squares. Only another 1/3 were managed expectantly and delivered based on obstetrical indication. This triangle and circles. In here, blue dot shows severe cases, and red dot shows ventilation or ECMO cases. Shapes of dots shows delivery mode as before. Most of these severe case diagnoses before 36 weeks were still managed expectantly. And after they recovered from COVID, delivery around full term based on obstetrical indication. But once worsened, prompt cesarean delivery was chosen after 28 weeks. Similarly, severe cases after 32 weeks and ventilation or ECMO case after 26 weeks had delivered by cesarean promptly after COVID diagnosis or around indication of ventilation or ECMO. In short, prompt cesarean delivery due to COVID in mild to moderate case might be a divisive issue, but cesarean delivery due to COVID around full-term pregnancy was in our registry, it was common in Japan. I think it may have obstetrical, it might save obstetrical and midwives resource, and we might be able to prepare for next COVID patient. I couldn't show in this presentation mother-infant separation within 2 weeks after diagnosis for COVID was also common in Japan, and it might save neonatological resource. Fortunately, this situation was acceptable for most Japanese. Next, I would like to show the obstetrical complication observed after COVID-19. Occurrence of obstetrical complication after diagnosis of COVID-19 was compared between mild to moderate case and severe to ventilation ECMO group. In severe group, preterm birth and certain premature labor was increased significantly. However, most of preterm births were artificial, so we don't know spontaneous preterm births will increase after COVID or not. But certain premature labor also increased in severe group, so we have to keep paying attention about spontaneous preterm births after COVID and need further analysis. Lastly, about the risk factor for severe disease within pregnant women in Japan. By our registry, more than 31 years old at diagnosis, more than 21 weeks at diagnosis were risk factors for severe to ventilation ECMO illness. BMI more than 26.3 at diagnosis was also a risk factor. But obstetrical complication at diagnosis does not relate to severity of COVID-19. In regard to non-obstetrical complication, only the history of present illness of respiratory disease, it's mostly asthma, or risk factor for severe disease. Well, this brings me to the end of my presentation. Based on new evidence, we are continuously providing information and advice about COVID-19 and pregnancy. It contains vaccination and prevention of infection for pregnant women and women who are trying to conceive. In conclusion, this practice would mitigate panic among women and women who are trying to conceive, and they could act calmly and prevent infection under the pandemic. This could reduce the load to the obstetrical and neonatological resource. So we could manage normal prenatal care and prenatal COVID care in the most part of Japan. These 2 years, 5 waves, I think. Thank you all for your attention.
Thank you so much, Dr. Master Dekuchi from Kobe University Graduate School of Medicine. And now we would like to invite Assistant Professor Lee Soti, Deputy Director of National Maternal and Child Health Center, Cambodia.
Thank you. Welcome and good evening, organizer, delegate from all the country. Thank you, organizer, for inviting me to join today. Today, I have a pleasure to present you about sexual reproductive maternal health and reproductive rights in Cambodia during COVID-19 pandemic. As we all know that most of the country affected by COVID-19, since 2020, almost 2 years. Same for Cambodia, we have the first case of COVID-19 in February 2020. But Royal Government of Cambodia have good response to COVID-19. We have great COVID-19 vaccination coverage, present around 88% in 2021. Nice. The second slide is just short my biodata. I'm not a public health. I'm a gyneco-obstetrician, and my English not so good, but I will try to present in English. Yes, the impact of COVID on reproductive health. Next. COVID-19 current situation. I would like to talk to show about the vaccination report of COVID-19 from February to December 2021. We have 14 million people vaccinated with COVID-19 vaccine, equal to 88.80% compared with the 16 million population. Nice. Yeah. The National Maternal Child Health Center take action to respond COVID-19 pandemic, such as develop and disseminated the national guideline on ensuring the continuity of essential sexual reproductive maternal and newborn health services during the COVID-19 pandemic in April 2020. To continue implementation of this important guideline and timely program adjustment, including regular monitoring and supervision to health facility. Until now, sexual reproductive, maternal, and newborn health services remain functioning and available to women and girls. The sexual reproductive maternal health services status during COVID-19 pandemic. We have 4 points. Yeah. The first is regular monitoring and supervision. Back. And health management information system of MOPH, and review and access, including a recent rapid assessment to field monitoring and supervision still continue. Yeah. Okay. And second point is services status. Sexual reproductive maternal health services as well as other health services remain functioning across the country. Women, girls, and clients still can access the essential services. The third point, prolonged situation. We observe some decline of some services like antenatal care, postnatal care, and family planning due to fear after the infection. Fourth point, adoption and response. National Mother and Child Health Center, JICA, UNFPA, and WHO and other partners have worked out together to address such challenges, including promoting service information through social media, e-learning, and telemedicine. Even we have struggled all these problems, we have some challenges under COVID-19 context. Additional works load, the staff at all levels are very preoccupied with COVID-19 response. Lack of certain items also. Personal protection equipment, referral system. A few health workers experience difficulty in referral patients for higher level services. A few other detected conditions of women who come for delivery and try to refer women to higher level of care earlier, afraid of complicated cases under the staff at the health center. In-personal training, meeting, and coaching to healthcare provider has been disrupted. Health provider and client are afraid of being infected of COVID-19, even from each other. Pursue less friendly services by health provider. Very difficult to get permission from workplace in access care under the lockdown zone. The implementation of checkpoint is not a main barrier for access to sexual reproductive maternal health services under crisis. Yes. In conclusion, The sexual reproductive maternal health services remain open and functioning, but there were some challenges under the lockdown period mid-year. But there are some decline in service utilization in the public sector in 2020 and 2021 if compared to 2019. Community maintain the accessibility to public services with some changes of health seeking behavior and delay seeking care during the lockdown. Service uptake faces some decline during the lockdown, but remain accessible and gradually increase. Unchanged story of being afraid of infection when accessing care and providing care. Health system recommendation: develop workforce mitigation plan, rotation of health center staff to support COVID, but maintaining enough midwife health staff in charge of sexual reproductive maternal health at the health facility. Provide support to health staff, essential protection, supply, and psychosocial support. For the referral system, we have set up the protocol reporting and referring cases under the crisis more ambulances. Engage relevant stakeholder, local authority, community, representative, and health facility to support emergency referral pathway, especially under the lockdown and high-risk zone. For the policy and program recommendation, while the focus is made on COVID-19, we must ensure continuity of health services, particularly sexual reproductive maternal health services, throughout the pandemic. Yeah. Implement national guidelines on ensuring the continuity of essential sexual reproductive maternal health services during COVID-19. Use village health support group as the channel of community to distribute basic family planning services and some basic sexual reproductive maternal health information during lockdown and travel restriction. Provide the health education and key message on antenatal care, family planning, postnatal care, and other essential services through social media and telemedicine. Yeah. And consider outreach activity home-based care for women in high-risk zone. Continue to monitoring and supervision in this stand mode to ensure the continuity of sexual reproductive maternal health services. Dignity kit to support poor and vulnerable women victims of gender-based violence. And this is the last slide. In Cambodia, there is no evidence of the service interruption, but there are some decline in service utilization at the public facility if compared to prior COVID-19 pandemic. But we do not significant notice the services, yeah, in the COVID-19 pandemic. Yeah. Thank you.
Thank you so much, Dr. Soti from Cambodia. And now, please welcome Dr. Dat Van Duong from Sexual and Reproductive Health Specialist from UNFPA Vietnam Country Office.
Dr. Duck, please unmute your microphone.
Good evening to you all. It's my pleasure to be here, to be with you here today. And thank you for the organizers for giving me a chance to be here with you to share the lesson learned from Vietnam. So could I have my presentation, or I will share screen from my computer?
Could you share from your computer if possible? Thank you.
Yes. So today I would like to present to you very brief presentation of the impact of the COVID on maternal health in Vietnam. And in my presentation for 12 minutes, I will present current COVID situation in Vietnam, and then I will present estimated impact of COVID to maternal health and family planning according to our modeling study recently. And I will present also our effort to maintain provision of service without disruption. Then any remaining challenge and lesson learned from us, and then our recommendation. So I would like to give a snapshot of Vietnam. So you could see here from the updated data released this year and last year. So for unmet need for Vietnam for this year, according to our survey, is about 10%. School birth attendance is 96%. And contraceptive prevalence rate is 72%. While you see that health insurance is quite a high, 90%. So here is a maternal mortality ratio trend in Vietnam. You could see that in past 20 years, over 25 years, maternal mortality in Vietnam sharply reduced from over 200 by year 1990s to 2020 is about 46 maternal deaths per 100,000 live birth. And I would like also give you a very brief picture of COVID situation in Vietnam. And the first case was detected on January 2020, and the country's experienced 4 waves of COVID. And the first wave during January and June last year, and the current wave started from May this year and up to date. And today we have about over 16,000 cases of COVID just for 24 hours. And you could see the quick pictures about total number of cases, 1.4 million, and number of deaths is over 27,000 deaths. And the vaccination that start very late in May, however, it's rolling out very fast. Today we have over 25,000 fully, over 65% of fully vaccinated people. So from now to the end of December, the country will reach 70% of fully vaccinated. And now I would like to present to you our study on modeling of COVID-19 impact on maternal health. And the study was conducted by UNFPA Regional Office, APRO, in collaboration with Vietnam Country Office and Ministry of Health of Vietnam. And the analysis performed through Spectrum and using the modeling software developed by Avenir Health. And our research method is in line with Johns Hopkins University study and other global studies. So it could have some international comparison for the result. So in our studies, the modeling, we modeling the impact of COVID to maternal health and family planning. 2 indicators we measure are maternal mortality and unmet need for family planning. 2 scenarios we will apply. Best scenario, when the service utilization in each population group decrease at an average level, and worst case scenario, so we go to at lowest level. During time shortage, I'm not able to present to you all our parameter and assumption, but in case you are interested, we could send to you the full report. I would like also note that here in our study, we estimate the impact of COVID to maternal health for the first wave of COVID. It means come from January to May last year, 2020. January to June, year 2020. And we based on the data from maternal deliveries and contraceptive use reported by HMIS system by MOPH between Q1 of year 19 and Q1 of year 20. And we base the updated data from our national census on 2019. And here we also stratify our population by 4 groups. Group 1 is very good. Group 2 is good. The group 3 is average, and group 4 is the most vulnerable, where the place they have very weak health capacities and socio-economic condition. So you could see that the percentage of whole population in our research assumption. And data found that compared to the baseline without COVID, we estimate that by year 2020, maternal mortality would be 44 for 100,000 live births. In the worst case scenario, it will climb up to 62. And in the worst case scenario, it will go up to 69 maternal deaths per 100,000 live births. In terms of total maternal death cases, you could see that for the baseline of 2020 without COVID, the country may have total 677 deaths. In the worst case scenario, we will have an increase of 443 additional maternal deaths. And in the best case scenario, it nearly 300 additional deaths. And in terms of unmet need, please also note that for nearly 10 years, the unmet need for married population is about 6.6. And in our modeling exercise for the first wave of COVID, in the worst case scenario, unmet need increased 1 percentage point. However, you know that in my earlier presentation, in the picture of Vietnam, snapshot of Vietnam, according to our national survey, population-based survey, we already found that unmet need for year 2021 is 10.1%. So key findings from our study, I will summarize as follows. You could see that in the worst case scenario, maternal deaths increased by 65%, and in the best case scenario, increased by 44%. It means that the progress of Vietnam in sexual and reproductive health was pushed back by year 2010 in the worst case scenario, and by year 2015 in the best case scenario. So we could see that the impact on maternal health very, very severe. And now I would like to present our effort to maintain sexual and reproductive health services in Vietnam. So at early onset of the pandemic, the government already have great effort to promote for multi-sectoral collaboration for COVID-19 response. the national guidelines on provision of SIS services without disruption was introduced very early time in March year 2020. And the government also promotes for a mix of hybrid and online working modalities at all sectors. And telehealth services, for example, the Maternal Health 24/7 smartphone application was strongly promoted to and government and also development partners also put a lot of effort to strengthen service provision network. For example, providing more medical supplies and consumables, including PPE and vital equipment for maternal health, like electronic Doppler or fetus monitors. Government also promotes for online training programs on provision of SIS services, and in many areas in the fourth wave, they also mobilize the health worker from low pandemic areas to support in hotspot places. And in recent recent months, from November to December, we started sharing lessons learned and best practice from hospital in Ho Chi Minh cities, where you know that in the fourth wave of COVID is the most severely affected, to see how they survive to keep the service going on in the heart of COVID. And as I already mentioned, the vaccination program for COVID-19 quite late compared to other countries. However, the rolling out of vaccine COVID very, very rapidly nationwide. And the country will reach herd immunity level by the end of this year, definitely. And the government also launched a large health education program on mass media and social networks to promote 5K. Everybody in Vietnam talking about 5Ks at the moment, meaning that social distancing, face mask, infection control, avoid gathering, and medical declaration when you travel. And the government also starts at early times the national social protection initiatives. About the remaining challenge for Vietnam, you could see that decentralization issues is promoted in the healthcare system over years. However, it may have very negative disadvantages for the COVID in the way that each province may have their own strategies in terms of COVID control and service provision, and not necessarily that a policy from a country will be interlinked with the need from other countries. For example, one province will introduce a lockdown in the whole province, and that may affect the supply chain, the traveling, and the whole country may stop. For example, in Ho Chi Minh City case, they just stopped in next door province, and then all the transportation go to Ho Chi Minh City and other provinces will be blocked. And we lack of skilled providers for maternal health, because in many provinces, in many hospitals, health facilities, SIS providers are mobilized to COVID control or seconded to other provinces for helping them to control COVID rather than for SIS services provision. And you also see that vital SIS data recording and reporting may be neglected when they compare to the need for COVID control. And we also observe that in the media, the lockdown of many big hospital, women hospital or SIS facilities. And clearly that may be observed in many other countries. the shortage of national and subnational budget for SIH. And we also see the disruption of supply chain for family planning commodities. And another issue is that during the pandemic, in high COVID transmission areas, the issue of quality assurance for commodities and service during the pandemic is a really big problem. Today, we open the media, we see that very big news on corruption case for procurement of COVID-19 commodities. And it's also linked with the issue of how to make the procurement and fast-track procurement safe and transparent. And you also see from community side that lockdown and social distancing will prevent women from seeking care from health facilities. And we also see that every day is negative and fake information on social media about the COVID, about the vaccine, about the maternal health care at health facilities. We see that every day. And you could see that lack of jobs, income, more stress for women, men, and community, mental health issues. And it's a big thing we really have to consider when you do programming for SIH amid COVID-19. Another issue for Vietnam is that the country is severely affected by climate change and humanitarian crises. Last year, we had a series of floods during the heart of third wave of COVID. And so double twice to the communities when they don't have food to eat, but then they have to be also affected by COVID situation as well. In this situation, people, you could see that very low utilization of service because health facility both lockdown and also negatively, badly affected by a disaster. So now we would like to give you some brief recommendation. I would like to address first with the need for further strengthening primary health care. You know that I would like to give a case of Ho Chi Minh cities and many Mekong Delta provinces when the COVID occurred in the fourth wave. The whole healthcare system really collapsed. For Ho Chi Minh City, the total population for registered population is 9 million. However, for migrant workers, it accounted for another 5 million. However, the public primary health care just designed to serve registered population. And the migrant workers have to use a private healthcare network, but they are not actively participating in COVID response because of payment financing mechanism from government not very clear to include private sector in. And monitoring and supportive supervision from higher level in Ho Chi Minh cities and other southern provinces quite weak compared to the north. So you could see that when the number of COVID in spike, the whole system collapsed. And it's luckily that we have the healthcare workers from the low pandemic areas come to the south to support them. Otherwise, situation can be unbearable. And the next point is how we could keep referral system for complicated case work during the pandemic, particularly in remote areas. And we really have to consider how to deal with the shortage of health personnel by mobilizing more health personnel from provinces with low incidence of COVID, and also personnel from private sectors, from army, from police system to work for both SIS and COVID. My last slide. And for the government, really important for the government to make any necessary revision for financing and procurement policy for COVID commodities to make sure that the procurement is a faster track and transparent in terms of pricing and suppliers and have quality assurance. For example, we are not very clear for the suppliers, face masks or other item of PPEs. How many % of them available in the countries meet required standards? It's very unknown at the moment. And in terms of health workers, at the moment, we need to further improve policies and measures to make sure that health workers are protected at health settings. Because there's a big concern about the safety of health workers, particularly who directly involved with COVID-19 control. Finally, I would like to address that from our modeling study, a small drop in access to modern contraceptives could make very strong impact on the increased number of unintended or unwanted pregnancies and directly leading to increase of maternal mortality. So it's very important that for the government and other stakeholders to have sufficient investment on national family planning program to ensure no disruption in supply chains for modern contraceptives. So I would like to end my presentation here. Thank you for your patience, and I would like to wish you a Merry Christmas and Happy New Year. Thank you.
Thank you so much, Dr. Dadwen Duan from Vietnam. And now I would like to invite Dr. Pise Lumpikanon, the professor from Faculty of Medicine from Khon Kaen University, Thailand. ครับขอเชิญครับอาจารย์พิเศษครับ For the comments by health system expert.
Thank you very much, Dr. Ekachai, for your introduction. I would like to thank the organizing committee of this Prince Mahidol Award conference side meeting for inviting me to be a commentator. And I would like also to thank all speakers for their excellent presentation. Let me give my reflection starting from Thailand. Thailand currently has more than 6,000 pregnant women infected with COVID-19. Interestingly, among these women, only 519 were vaccinated. That is less than 10%. And these women had a mortality rate of 1.7%, which is more than 2 times of that in general population. There was a severe disruption in antenatal care, family planning, postnatal care during the pandemic peak. Efforts that have been implemented by the Ministry of Public Health of Thailand include service delivery by using telemedicine, one-stop antenatal care, referral system, and universal health coverage. Also, public communication to give information how to avoid and prevent COVID-19 infection. The policy of work from home has been implemented widely, both public and private sector. Vaccination of COVID-19. Unfortunately, vaccination for pregnant women policy was implemented quite late compared to other 7 priority groups. So the remaining challenge in Thailand include health information system because of the incomplete data, fake news, especially about COVID-19 vaccination, and inequitable resources allocation, including vaccination. Moving to Laos, during this COVID-19 pandemic, some essential services have been disrupted and still not yet caught up. Efforts that have been put together include database policy development and service delivery, evidence-based technical recommendation for safe provision of reproductive, maternal, newborn, child, and adolescent health was developed. It is very interesting to observe that one of the very important policy in Laos is that after childbirth, babies should be with mothers, even with confirmed COVID-19, and receive immediate skin-to-skin contact at least for 90 minutes and initiate breastfeeding. Community engagement module can promote health beyond health sector. Strengthening primary health care was implemented for the uptake of sexual and reproductive health. Coming to Japan, the effort that have been put include provision of information and advice to both general public, including women, and also healthcare provider. And these information were updated regularly. Second important effort is registration of COVID-19 in pregnancy. So far, surprisingly, only 346 cases. This is up to until 31st of October. No severe effect in pregnant women and fetus were observed. Risk of severe illness was only 1.7% and not increased by pregnancy. If I understand correctly, there were no maternal deaths in Japan because of the COVID-19. And in women with mild to moderate COVID-19 infection, about 2/3 of them were delivered by cesarean section. This surprised me very much because I know that Japan is one of the countries with the average cesarean section rate of only about 15%. And also the other interesting issue is that mother-infant separation within 2 weeks after diagnosis for COVID-19 is recommended. Maybe Dr. Dekuchi can elaborate a little bit more on this. Risk factor for severe disease in women include age more than 31 years, gestational age more than 21 weeks, BMI more than 26, and history or present respiratory distress. Let's go to Cambodia. National Maternal and Child Health Center of the Ministry of Health together with UNFPA took early action in developing and disseminating national guidelines on sexual and reproductive health with regular monitoring and supervision. Sexual, reproductive, maternal, and newborn health services remain function. Cambodia has a very impressive COVID-19 vaccination. Challenge include decline in some services, for example, antenatal care, postnatal care, family planning, due to fear of infection, but not totally disruption. Promote service information through social media and telemedicine. Additional workload because of the COVID-19, some problems in the referral system, and limit training of health personnel. Coming to Vietnam, I observed that Vietnam has a cesarean section rate of 34%, perhaps one of the highest country with the highest cesarean section rate in Asia. And decreased trend in maternal mortality ratio over the years. Interestingly, more than 133 million doses of COVID-19 vaccine has already been implemented, although start late. Interesting presentation was about the modeling of COVID-19 impact on maternal health was performed by the Ministry of Health in collaboration of UNFPA. And by this modeling information, using the information between January to June 2020, maternal mortality ratio will increase from 44 to 62 in best case scenario and 69 in worst case scenario. And unmet need of family planning will increase from 6.6 to 7.0 in best case scenario and 7.6 in worst case scenario. Effort to maintain sexual and reproductive health in Vietnam include vaccination, health education on mass media, mobilization of volunteer and community support. Remaining challenge include lack of skill provider in sexual or reproductive health, lockdown, fake information, and economic problem. Recommendation include strengthening of primary health care, better referral system, mobilization of health personnel, family planning services, and protection of health workforce. Issue that I want to emphasize in this side meeting of Prince Mahidol Award conference include, I think low COVID-19 vaccination for pregnant women is still a very big issue that we have to work harder to achieve better coverage for this, mainly because of the afraid of adverse effect, especially on the newborn. Increase in cesarean section rate for women with COVID-19. This is not according to the World Health Organization. We recommend that cesarean section for women with COVID-19 infection should be performed only with medically indication. This also will lead to the decline in breastfeeding because of the effect of unnecessary cesarean section. So we have to also focus on early breastfeeding, and it should be recommended in women with COVID-19 infection, although with precaution. One issue that was mentioned only in Cambodia was about gender-based violence. I think this issue should also be further explored and closely evaluate and manage in our society. Over to you, Dr. Ekachai.
Thank you so much, Dr. Pisek Lumpikanot Krab. And now I would like to go to the next session about the question and answer. And this is for the panel discussion. The first question go to Vietnam. The first question go to Vietnam. The number of women seeking contraception has decreased due to the COVID-19, right? Dr. Dat Van Duong.
Yes.
The question is about the number of women seeking the contraception has decreased due to the COVID-19. This is right or not?
Decrease. We have the data from Q1 2019 and also Q1 for 2020. It's clearly that you know that it's during that time it's a first wave of COVID. You already see very clearly that in some areas the contraceptive use, modern contraceptive use dropped from 5% to 25% in many provinces. And by that time, we estimate that due to the first wave of COVID, the unmet need increased from 6% to nearly 8% for worst case scenario. However, in our data collection for population-based survey study, already record that actual unmet need already increased from 6.5% to 10%, not about 7.9% as our modeling for married population. And for vulnerable population like young people, for ethnic minorities, the unmet need for family planning already reached 40%. So it's already clear evidence. And many provinces also report to Ministry of Health about the lack of modern contraceptives, could be possibly because of the block in supply chains.
Thank you so much, Dr. Dat Van Duong. And the next question go to Japan. were there any maternal deaths due to the COVID-19 in Japan?
Actually, our registry is not government-based, so maybe we are just asking most of facility in Japan who are doing delivery. So maybe I guess 5 to 10% is registered. But in our registry, no maternal death was reported, and also it was not reported by mass communication base. So maybe no maternal death reported in Japan. Actually, we don't access to central registry or by the government. So we don't know actually, but maybe in such case, mass media will report. So no report such case.
Thank you so much. The next question go to Thailand. Dr. Pimonpan, are you there? Dr. Pimonpan, อยู่ไหมครับ
อยู่ค่ะ Okay.
Okay. Why were the healthcare workers reluctant to encourage pregnant women to receive vaccines? ทำไมบุคลากรทางการแพทย์ส่วนหนึ่งถึงไปบอกให้สตรีมีครรภ์ไม่ต้องฉีดวัคซีนครับ
Yes. Because they worry about the efficacy of the vaccine, especially for some companies. They are still not confident about the vaccine provided in Thailand earlier on, as there were not sufficient data study done in pregnant women.
Dr. Ekachai, may I give additional reason?
Yeah, please, Dr. Pisek.
We discussed today at the National Health Security Office meeting that many healthcare providers are reluctant to recommend COVID vaccination for pregnant women because they were afraid that if some side effects occur, they would be blamed by pregnant women and their family, that this is because of the vaccine that was recommended.
Thank you so much. And the next question, I have the question to all the 5 countries, the same question. According to the policy proposal, do you have any policy proposal for the government in each country to respond for the protection for pregnant women and children from the COVID-19 pandemic and for the future pandemic that may happen in the near future? This question is go to Vietnam first. Do you have any policy recommendation for the government to prevent, to protect the maternal and child health from the COVID-19 pandemic or other infection in the near future?
We have to advise for the government. The first, this one for family planning. I mean, it's a very uncertainty for the COVID situation for the next year, and government and development partners have to work together to make sure no disruption in supply chain for family planning services to prevent unwanted pregnancies for people, for women. And the second, you know that for general hospitals, so we always have a OBGYN department, and somehow a government should have very clear policies to protect, to give priority for OBGYN departments, because we see pregnant women there, and given the scarce resource for low setting areas like in Vietnam, priority given to OBGYN department is very crucial. And there's a need for government to mobilize the SIS providers from low pandemic areas to support high the pandemic areas, and also avoid mobilize SIS providers for vaccination program, and also mobilize them for COVID control, because we also do observe this situation happen in many places, and women came to health facilities, but SIS providers, skilled birth attendant is not there. So it's our two recommendation for policy for Vietnam, could be for other countries. Thank you.
Thank you. Yeah, thank you so much, Dr. David Duong. And now I would like to ask for Japan, Dr. Deguchi.
Actually, we don't have any information about more accurate number of pregnancy cases. So we are just trying to get information by ourselves. And in Japan, the number of child is decreasing, and major number was elderly person. And in our city, we have 27,000 COVID case in all, but pregnancy case was only 102. So we, for not only COVID, but also all for increase children and child health care, I want to pay more attention to pregnancy patient, pregnancy person, women, and child. It's one point, and maybe we are very confused because we don't have no good information about COVID pregnancy. So we get information by ourselves, and we keep our healthcare system by ourselves, by almost by personal communication. So I would like to take more care about healthcare, and also healthcare for children by the government. And we don't have central registering system, and they have central registry system, but it's fax-based, so not real time, and maybe they don't know how the maternal case is occur in Japan. So maybe for future, it's very important to the national central registry system is very important, I think. Thank you very much.
Thank you very much. And now I would like to ask the same question to Lao. Yeah.
Thank you.
Dr. Chantham. Yeah.
Thank you, Dr. Ekasai. And in Lao, at a technical perspective, Adrian already know that we have some evidence based from the routine data correction. We recommend for the government to continue to maintain the essential services during the pandemic in order to make sure that mother and child can access to health facility in any situation in the country. So that's why we just recently endorsed the recommendation during the pandemic. So for example, like reproductive health, we try to promote the long-acting methods for the women that in order to reduce the number of visits during the pandemic. And for the ANC, for the pregnancy, we also try to shifting the services, because as I presented, the quality of care in all levels are not big different. So we recommend to shifting some services that should be provided in the local, in the subnational, rather than go to the designated hospital if they need. In case they have severe issue, they can go to the provincial hospital or central hospital. That's the recommendation that are from the perspective of technical that we are recommend to the government. And also we also recommend that beyond health, in order to improve the health in the community, only health sector could not be a success. So we try to collaborate with others stakeholder in the country, especially from the MOHA, what we call MOHA, Ministry of Home Affairs, they are dealing with the local authority. If we have the good collaboration and the good relation among the ministry and within the government state, we will have more authority to mobilize and promote it, health in the community as a nation. And also we also think about the improvement or strengthen the health information, because we now try to use the database for the strategic planning in order to make sure that any gap will be filled after we have some evidence to prove for the government. So we also now we're going to studying the resistance for the pregnant women who are infected, but we have been trying in some the retention center, but we still have very rare reported because the health staff, the health provider, they are not closely monitor the detention that much, so they only had just the phone call and consultant through the hotline. Thank you.
Thank you so much. The same question to Cambodia. Dr. Soti.
Thank you.
Are you there? Yeah.
Yeah. Thank you. In fact, the Cambodia royal government and Ministry of Health do a lot related to prevention, the COVID and infection for the maternal and child health. Even in Cambodia, another pregnancy women receive the vaccination, and for the child age 5 years or 5 to 12 years, and ours receive vaccination fight against COVID. The government, yes, and NHSO do more, but we suggest to maintain all these services, ensure that health and well-being of children and pregnancy women is priority and include in key government strategy and policy. Maintenance essential service ensure children and pregnancy women receive access when they need, especially for the poor family. Yeah, easy access to health. Set up protocol for triage and risk screening, referral system, and preventive measurement. Ensure health provider can delivery and services. Set up infrastructure for healthcare, like isolate service, rapid test kit, and etc. And ensure the representative from MCH and relevant stakeholders are involved in development of relevant government policy, strategy, and guidelines, to help the maternal and children. Yeah. Thank you.
Thank you so much. And now the last country, Thailand, Dr. Pimon.
I think about Thailand, we should strengthening the network, maternal and healthcare network for strengthening the referral system between each hospital, which we should be modify the service delivery to be the new normal, such as the telemedicine or teleconsultation, and use the digital platform to include in the service delivery. And most of all, we should have fully complete vaccination to the people, include the pregnant women, because now the pregnant women have to only 20% of all pregnant women in Thailand. Thank you.
Thank you so much. Thank you so much. And now in conclusion, I think COVID-19 is the biggest global crisis for mother and child in the history of the world. And the question is how to decrease the burden against the COVID-19 in response of the health facilities. Second, how to strengthen the database of the mother and child to be the precise and concrete database system. Thirdly, how to strengthen the quality of the health care, including the capacity of the health care provider. And also the next, how to strengthen the local community, local health government on the primary health care, and also how to have the community involvement for the protection of the mother and child health. And this is for my conclusion. And Dr. Pisek Lubikanon, do you have any comments or conclusion before the closing ceremony?
No, thank you, Dr. Ekachai. Your conclusion is already excellent.
And because of the limitation of the time, and now I would like to invite Deputy Secretary General of National Health Security Office of Thailand, Dr. Lalita. Please. And now we go to the closing remarks.
Thank you, Dr. Ekachai. Ladies and gentlemen, it is my pleasure to be here to provide some closing remarks for the successful PMAC 2022 side meeting. The main objectives of the meeting were to review the impact of COVID-19 pandemic to maternal and child health, to share lessons learned, and to identify policy implementation on how to respond quicker to protect pregnant women and children from the COVID-19 and any future pandemics. I believe the side meeting reached its objectives to a large extent. We have learned a lot from country presenters from Thailand, Laos, PTR, Japan, Cambodia, and Vietnam, who have shared their efforts and remain challenges of each country to protect mothers and children. We have also obtained insightful comments by Dr. Pisek, followed by fruitful discussion facilitated by Dr. Ekachai. Now, the world is observing that Omicron variant is spreading significantly faster than the Delta variant in countries. Amid ongoing pandemics, as some countries show today, the importance of scientific evidence has been increasing to identify more high-risk persons and take proper actions. The challenge is that we have to correct and analyze this data as quickly as possible to cope with changing situation. We have reaffirmed that significant health system incorporate regular monitoring system is essential to realize such an evidence-based response. The strong health system with effective referral system, as well as local health government and community engagement, is also a basis to ensure continuity of essential maternal and child health services at the same time as taking COVID response. I sincerely hope that through the presentations and discussion today, each of us gain own takeaways and will contribute to solving and preparing for the challenges in our countries to protect our future. Lastly, I would like to thank all speakers and participants who have joined this side meeting from all over the world. I would like to thank all the Secretariat members for organizing this side meeting and ensuring that it proceeds smoothly. Last but far from least, I would like to thank PMAC Secretariat to give us the mutual learning opportunity. Thank you.
Dr. Ekachai, please unmute your microphone.
Yes, sorry. Okay, thank you very much. And ladies and gentlemen, now we come to the end of the meeting. Thank you so much, everyone, for the joining of the side meeting of protection our future, mitigation of the impact of COVID-19 on maternal and child health, and hope to see everyone soon in the near future. Thank you very much, and thank you for NHSO, Department of Health, Ministry of Public Health, JICA, and also participants from Thailand, Laos, Vietnam, Cambodia, and Japan. And see you later in the near future. Thank you very much. สวัสดีครับ ขอบคุณครับ
Happy New Year to you all.
Merry
Goodbye.
Christmas, Happy New Year.
Bye.
Happy
Bye.
สวัสดีค่ะ
Thank you very much.
ขอบคุณใจก้านะครับสำหรับการประชุมวันนี้ราบรื่นดีมาก Thank you very much, JICA, Thailand.
Thank you very much.
Thank you, JICA, invite me.
Thank you for your wonderful presentations and moderation.